The gentleman from Iowa, Mr. Braley.
Competitive bidding. Sounds like it would be un-American to oppose something that sounds so important. And yet, competitive bidding will lead to the now disproven model of too big to fail in the durable medical equipment industry. Because companies that can lower margins and try to make it up on volume are going to drive providers out of the market in places like my state of Iowa. We know that's going to happen. You don't need a PhD to figure that out. The competitive bidding program has been plagued with problems from the beginning. Even proponents of the program readily admit that the implementation process was problematic. CMS delayed the bid window deadline several times, provided bidding instructions while the bidding window was open, sometimes provided unclear guidance to bidders, operated an electronic document system that failed frequently, and didn't notify suppliers that their bid information was incomplete. Put frankly, this program has a poor track record. Now we have evidence of the devastating impact on beneficiaries like my constituents who depend on medical supplies, especially in rural areas. A recent study by Dr. Kenneth Brown, a professor of economics at the University of Northern Iowa, concluded that the competitive bidding program for DME will have a significant negative impact on rural areas which are specifically excluded from the bidding process. Dr. Brown reached this conclusion based on a study of the current state of the industry, the financial results across the industry, and the 32% average reduction in reimbursements that is resulting from round one bids. Specifically, Dr. Brown believes that my home state of Iowa will lose 40 to 50% of its DME suppliers in the aftermath of competitive bidding. That is unacceptable to me and the people I represent. Now, despite the data and track record, CMS has moved forward again on its round one rebid, and the problems are surfacing again. In addition to questions about the impact in rural areas, other questions have arisen about the level of transparency in the process so far, and this is a bipartisan issue that almost 150 of my colleagues have raised concerns about. I would hope that CMS would go above and beyond to provide full and open transparency into the bidding process, which has been a high priority of the President. Unfortunately, though vital information is unavailable for both Congress and the Program Advisory and Oversight Committee about how those rates have been determined, access to care for beneficiaries, and the impact on small providers. For all of those reasons, Mr. Chairman, I'm glad you decided to hold the hearing, and I look forward to having many of these questions finally getting the answer they deserve. And last, I would like to request unanimous consent to submit the following items to the record: Dr. Kenneth Brown's study on the impact of competitive bidding in rural areas, testimony by Jim Tosey, a member of the Board of Directors of the Center for Regulatory Effectiveness, and on behalf of Representative Jay Inslee, a letter from Care Medical and Rehabilitation in Seattle, Washington.
Without objection.
Thank you, Mr. Chairman. Mr. Wilson, I'm going to start with you. I wasn't here when competitive bidding was made law, but isn't it true that there's a lot of ways that you can address the issues of waste, fraud, and abuse that wouldn't involve competitive bidding?
There are certainly many ways for addressing this problem.
And in fact, in Mr. Levinson's written testimony that he's provided to the committee, he documents a lot of the work that the OIG has done to try to address the enormous problem we have in healthcare delivery with waste, fraud, and abuse. And at the conclusion of his recommendations, he notes, it is critical that these and other program vulnerabilities be addressed, be it through competitive bidding or otherwise. And that otherwise is a huge sector of healthcare delivery that involves diligent oversight and management. You would agree with that?
That is certainly one of the areas that we would need to pursue in order to solve this problem.
Has CMS, to your knowledge, done an analysis of the impact of the competitive bidding process, not just the initial phase, but as it is intended to be implemented throughout its entirety on rural healthcare delivery?
We have not done that type of analysis to this point because rural areas are excluded from the program. We have not yet done rulemaking on how to expand the use of those prices by 2016, where we would do such an impact analysis.
Okay. Do you understand why patients in rural America have serious concerns about a shrinking market to meet their health care demands if the impact of the long-term competitive bidding process results in the shrinking of available suppliers and an unwillingness on the part of some of the remaining people who are eligible to participate to go into areas where volume will not allow them to achieve the type of margins they could have factored in when they presented their initial bid application?
I think that what beneficiaries need is choice and quality, and I think that can be sustained under this program.
Okay. Are you aware that in a host of other purchasing opportunities that people in rural America have substantially fewer choices in the marketplace than people in more populated areas?
I think it's certainly true that there are challenges in rural health care.
Okay. Have you ever lived in rural America, Mr. Wilson?
I have not.
Okay. Well, I have. I grew up in a town of 1,500, and most of my district is considered rural America. And we see lots of policymakers who come to committee hearings like this and try to tell us how they're going to fix the problems in rural America. But I can tell you that for those of us who deal with these problems on a daily basis, this is more than just paranoia. This is what we have seen happen on the storefronts and shops in our cities and towns. It's a problem where every time a drugstore goes out of business in a rural community, it denies access to people who need durable medical equipment. Every time a provider who is furnishing DME services to those small town hospitals and healthcare providers, once they go out of business, we aren't as confident maybe as CMS is that the big players are going to be willing to come to our part of the country and continue to compete for our healthcare dollars. Do you believe that a decrease in the number of suppliers in rural areas could impact accessibility and timeliness of receiving durable medical equipment?
I'm not sure that we're going to see a decrease in suppliers in rural areas. I think we have not moved forward with the authority that we have to apply the prices in rural areas, and of course competitive bidding does not apply there.
Well, as Johnny Cash saying, I hear the train a-coming, and I think everybody in rural America knows that this is inevitable. Mr. Levinson, I really was interested in a number of the comments that you made in your report. I want to focus on a few of those. You appropriately noted the challenges that we're facing in healthcare. We talked about this a lot on this subcommittee in dealing with what some people have identified as a $500 to $700 billion problem in this country, not just in Medicare, Medicaid, but across the healthcare reimbursement system in waste, fraud, and abuse. And you've identified enrollment, payment, compliance, oversight, and response issues that need to be addressed. One of the things you talked about was that DME is one of those areas where we see problems with people getting in at the entry level, and then it becomes hard to monitor them once they're set up and doing business. But I guess I'm a little confused because if the purpose of having a certification requirement that a good or service is medically necessary before it can be prescribed and paid for by public or private reimbursement systems, why is it a challenge for anybody receiving Medicare payments, whether they're DME providers, pharmaceutical providers, or other health care providers, to be identified at the point of entry and be held to a level of accountability that protects consumers of health care in this country?
Well, over time, it has certainly become apparent that it has been too easy to get a provider number. Enrollment has been a fundamental flaw for many years in terms of just gaining entry to the program. When our auditors and evaluators, for example, went to South Florida a couple of years ago and just banged on doors or tried to bang on doors because actually there were no doors to bang on, we found that about 1/3 of the 1,500 or 1,600 DME providers in South Florida, those who had registered and gotten a number, didn't make even the most basic standards for being able to gain entry to the program, like having a physical location, like having regular hours, staffed by somebody who could actually help. So it is quite clear that it has simply been too easy to gain access, and to the extent that we can fix the enrollment issue among those 5 issues that you and we have identified, you really solve a lot of the consequential issues that we have to deal with when it comes to compliance, oversight, and response.
Oh, I know.
Doesn't necessarily deal with pricing methodologies, with being able to align prices so that they better reflect market realities. And some of our pricing reports indicate that Medicare indeed pays too much. And, you know, we have done some comparative work, not just with VA, which one might argue is a different kind of structure, but with the Federal Employee Health Benefits Program as well, and with Internet pricing. So the pricing issues are perhaps somewhat related to enrollment, but I think that the enrollment issue, to the extent that we can get on top as a department of the enrollment issues, that will solve a lot of the blatant fraud issues. And again, you know, fraud is a segment of a larger issue. Well, one of the most promising aspects, actually, of the Affordable Care Act is the mandating of a compliance program for healthcare providers. And I think by having compliance built in to Medicare going forward across a wide range of industries, we'll be able to do a much better job of protecting taxpayer dollars and actually giving value to beneficiaries.
All right. Thank you for your time. I yield back.